Hello, and thank you for joining us for what I hope has been interesting and informative discussion around some of the latest data in rheumatology. We're talking today, my name's Professor Peter Nash from the Griffith University in beautiful downtown Brisbane, Queensland, Australia, COVID-free. And today I'm delighted to be joined by Professor of Infectious Diseases, Public Health, Preventative Medicine, and what I find most interesting, ophthalmology, from the Origin Health and Science University in the USA, as well as a CSF steering committee member, Professor Kevin Winthrop. Welcome, Kevin, and thanks for giving up your time. We greatly appreciate it. Today, we're going to be discussing the recently published in the Annals of Rheumatic Diseases, a safety study of filgotinib, the JAK1 selective, or now they call it JAK1 preferred JAK inhibitor as a treatment for rheumatoid. So before we get the ball rolling, Kevin, how has COVID affected your practice? What's the Omicron done to you guys? And have you seen some major changes?
Yeah, I mean, we're still kind of cleaning up our Delta surge here, and Omicron really just got here in the last 2 weeks, and it has already in 2 weeks, really exploded. And at least in my territory, it's actually less than 50% of the cases, but nationwide in the US, you probably read in the paper, it's about 3/4 of the cases now are Omicron, really just in the last 2 or 3 weeks. It went from 0 to 73%. So it is, we haven't seen a big surge yet alongside that. So I don't know, we'll see. I mean, that may just be coming. We're looking, for a 1 or 2 week lag when that happens to see what happens at hospitalizations and whatnot. But I know in some of the other countries, they haven't seen rises in hospitalizations yet, despite the increase. I don't know how it is in Oz, but are you seeing something similar?
Yeah, we're starting to see the Omicron come in, but we're not seeing the hospitalizations yet. So We'll wait and see. Yeah, but as you say, it's early days and our numbers are very small compared to many other countries. Let's talk a little bit about the JAK inhibitors.
Yeah,
I wonder if you've got a feel for the market there and whether oral surveillance has had a big impact on the prescribing of JAKs and the whole positioning of JAKs in that market.
Yeah, I mean, certainly the FDA's label change that took place a couple of weeks ago, everyone was anticipating it, since ACR when all that data was showcased. But I do think it's caused a shift. I mean, there's very clear direction now from the agency that, we should be positioning JAKs essentially behind TNF blockers in anyone over age 50 who's got cardiovascular risk factors, which is, most patients. So I think it has changed prescribing practices already. Maybe just as the pandemic's already changed some prescribing practices. So there's a lot to think about now as a treating rheumatologist. It seems so much easier a year ago.
That's right. The world has shifted on its axis. That's correct.
Yeah.
So let's talk a little bit about this paper. It's an integrated safety analysis of filgotinib in moderate to severely active RA receiving treatment. The median was about 1.6 years, but they had a few patients out to 5 years. Can you tell us a little bit about that Finch program for those people that don't know it and that you pooled all together for this study?
Yeah, you bet. This, this was the culmination of many years of the development program for this molecule for RA. So this was looking at phase 2 and phase 3 data as well as LTE data from that program. So it was collected over a number of years. I don't know how many years, but I was involved in the phase 2 and then the phase 3. It seemed like it took 4 or 5 years to get through all that, but it was nice. It's a fairly large collection of data. It's similar to the other JAK programs in terms of the numbers and the length of time of exposure to the JAK inhibitor prior to the finishing of the program and approval. And as you know, Filgo did not get approved here. It was kind of put on hold, and I think FDA wanted more data, so the decision was made to transfer the molecule back to Galapagos from Gilead. And so Galapagos, of course, is approved. They did get it approved in Europe in a number of places, and so I know people are starting to use it, which is great. So I think this safety data from this analysis lays the roadmap for what we might expect, and for certainly the things we want to study in the post-marketing period. Just to hit highlights, I mean, I guess the FDA's label change that came from TOFA data in a very specific post-marketing study now has been, of course, extrapolated across all the JAKs, and I guess it would include Filgo, although Filgo is not in the market here, so FDA didn't speak to Filgo. But Filgo, it does look a little different in this analysis, just in terms of some rates are slightly lower than maybe some of the other programs, and whether that's due to different programs being done in different places at different times. It's hard to compare these clinical trial development programs, and I don't think you can. So I do think you got to wait till there's this post-marketing, use of the drug.
Registry stuff,
Yeah, we
can
do
you
some
explain
head-to-head studies, yeah.
For those people who are not clear, could you just explain what an EAIR is?
It's just an exposure-adjusted incidence rate. So, it's basically what all incidence rates should be. It's just you're putting cases of whatever you're following in the numerator, and the denominator, you should simply have the exposure time, the total exposure time of the individuals at risk for that outcome. So that's.
Is it a way of accounting for shorter placebos and shorter comparator times compared to the longer term?
Yeah, exactly. So, when you're looking at placebo-controlled time periods and everyone's at 16 weeks, 24 weeks in all the arms, and of course you can just kind of look at percentages, but once you start, getting some trials that have different time periods of exposure, and then you add the LTEs, and, obviously you're getting wild with exposure times being potentially different between exposure groups. So yeah, so then we really want to focus on incidence rates at that point.
Yeah. Because the stuff presented at various meetings, we get this flavor that there might be a bit less zoster, there might be a bit of safety related to JAK1 selectivity. So what did you actually find in the study? Was there a dose response, for example? We keep trying to work out 100, 200, efficacy a little bit better with 200. Is there safety difference between the two?
Yeah, what I thought was interesting is I know this data forward and backwards, having been involved in it so long, and there is not a dose response really that's observed in this program. And my interpretation,
efficacy or safety?
Well, from a safety standpoint, and there is a little bit on the efficacy side, and you could better comment on that. But from a safety standpoint, these doses look very similar, which was why I was a bit surprised about the FDA's ruminations about this. I'll show you what we found. I mean, for example, what struck me as fascinating is that for serious infection, the rates of serious infection were right about the same as all the other JAK inhibitors in their programs, and very similar to what we see in TNF blockers, and actually most of biologics in their phase 3 programs. So the rates of infection were, on average 2.5 per 100 patient years. But what was interesting, Peter, is that the rate for the 100 milligram dose was statistically significantly less than the rate for the 200 milligram dose. It was 1.6 for the 100 and 3.1 for the 200. So it was almost double for it was 1.6 for the 200, 3.1 for the 100. So it was almost double the rate in the 100 milligram dosage. So that was totally backwards, right? And
yes,
what do I think? Do I think that's realized? No, I think it's a fluke. But what it tells me is I think probably the risk is very similar with the two doses. If you looked at zoster, you saw what we thought we'd see. You see a slightly higher rate with the 200 instead of the 100. So the flip, the converse to what we saw with serious infection. And there the rates were 1.8 per 100 patient years versus 1.1 per 100 patient years for the lower dose. But even those rates, as I mentioned, were quite a bit lower than what we saw in the other JAK inhibitor programs done earlier. So
yeah, just to put that in perspective, with the infection, we expect 3 per 100 patient years just from prednisone and methotrexate alone. And we expect 3 per 100 patient years zoster rates in sort of America and Europe and whatever. So if anything, it's kind of lowish, which either is a selection bias thing, because it wasn't vaccination, was it? Very few people were vaccinated,
Yeah, very few people were vaccinated. I mean, I would think more were vaccinated in this program than say the TOFA program that was 10 years earlier. So I certainly think there's probably, maybe less people at risk in this program than say one that was done 6 to 10 years ago. But in the phase 2 program, it was a bit different because the regions, there wasn't a lot of Asian representation in the phase 2 program. In fact, my memory is that there was really none. And of course, that's where we see the highest rates with all the JAK inhibitors. So in phase 3, I do know the regions and the enrollment were somewhat similar, very similar to the other programs. But again, the time period was quite different. So it's hard to know, how that time period could account for differential vaccination or just even at risk due to prior exposure, things like that. So
The other funny thing was that the risk factors for zoster in this trial, age over 65, but being on steroids didn't seem to make any increase in risk, and being on concomitant methotrexate, that's kind of didn't make sense.
yeah, it's interesting. So with the TOFA data, we definitely found, initially we kind of thought we saw some risk additional with methotrexate and prednisone. Eventually the methotrexate, when we had more exposure time and we modeled it, it wasn't a risk factor, but the steroids definitely added to the risk, right? And we know steroids are a risk and they should add to risk. In this program, and actually in the UPA program too, I mean, when that was modeled, we really didn't see steroids come out as an independent risk factor. And so, I don't know what the reason for that is. Sometimes you think, well, maybe it's because whatever the other risk factors are so strong, adding an additional one doesn't really change it, right? Maybe they're already at high risk enough from their JAK inhibitor or some other factor that, steroids don't really make a difference. That's kind of one idea, but the other idea is you're just underpowered, or the other idea is maybe
Sure.
This was random, we're not seeing it.
Yeah,
so
fair enough.
I don't know, but it is interesting. And I mean, I have to believe that steroids are we know they're a risk by themselves. So it would make sense that they either don't change the risk much when added to a JAK inhibitor, or they would enhance the risk.
And the history of zoster tripled the risk. So they're the kinds of things we have to make sure we remember to ask our patients about.
Yeah, so that was, to me, the most interesting thing is that, in the TOFA program, when we went through that, we never asked people about the history of zoster. We didn't collect that information. And that's fascinating to me that is, it turns out to be one of the strongest risk factors, at least what we saw in this data. And it's very counterintuitive because in general in life, most people, I mean, almost everyone who has zoster, they have it once and they don't have it again. And the idea is that, of course, you've basically vaccinated yourself when you have it, right? You boost your immunity and you should be protected for a long time period. What's fascinating is that in each of these JAK programs, there's this group of people that they just don't do that. They actually have recurrent zoster. It's about 3 to 5% of patients in all the JAK programs that have recurrent zoster during the program. So they're clearly not boosting their immunity when they have their outbreak. And I don't know why that is. There's something different about those people. Just like, and it may have to do with the fact that they're on a JAK inhibitor, and that's that's the issue, that it's not allowing them to build the immunity that they should. So I will be very interested in the vaccine studies that we're doing and a few others are doing to look at this issue. People who are on JAK inhibitors, when you actually vaccinate them, what happens? What's the immunogenicity and what's the long-term efficacy? So those are things we got to figure out.
And I think if we think zoster with the JAKs, you wait till anifrolumab, the interferon inhibitor, comes. That's going to really give us some zoster. So we better talk about the other things that were signals from oral surveillance, VTE, MACE, and malignancy. Any kind of comments about this clinical trial program and those things?
Yeah, my only comment would be we really didn't see those things. I mean, the numbers and the rates of those things are really low. There were no VTEs in the placebo-controlled trial periods. So that's unlike the other programs, and particularly Barry, of course, where there was this imbalance between the two arms in the first 12 weeks or 16 weeks. So there were no cases here. And then overall, the rate was quite low for VT. I think it was like 0.2 in the 200 milligram arm, and I think it was 0 in the 100 milligram arm. So we really only had a handful of cases. In fact, 8 or 9 cases throughout the whole program. So that was quite low. The malignancy rates were kind of right in the ballpark of what we see in all the JAK programs. I think 0.6, 0.5, and we're usually bouncing between that and 0.8 when you look at those programs. Again, as you know, these are short-term data sets. Malignancy, it's not a great place to study malignancy, given the long latency of those events. And then, the MACE rates were, right where they should be, and they were quite low. That's the answer there. I mean, if I looked at this data, I would have no sense that this JAK inhibitor or JAK inhibitors in general are a risk for some of these things. So oral surveillance is really just this landmark study where a lot of these findings, I think, were driven by age, higher dose TOFA, and probably some other factors. But clearly, I think you can hear where I'm going with it. I'm not sure all the JAK inhibitors carry the same risk, and I think at lower doses, they're all pretty similar. And when you get in terms of their risk factors, particularly when you use them in younger people, right, you just don't see as much. As many adverse events, which is really true of any drug, I guess.
Yeah, that's what I was going to ask you. Do you think there's any point in pulling out the over 50 with a cardiovascular risk and seeing what happens, or will the numbers be too small?
From this program, the Filgo program?
Yeah.
It's an interesting idea. We didn't do that. We modeled age, for some of the outcomes, of course, such as herpes zoster, but there were so few VTEs, for example, Peter, you just couldn't even look at that. So, it's going to require longer, bigger trial programs and, or, post-marketing studies.
Or registries and stuff.
Yeah, registries. I mean, that's true of the Barry, that's true of all these compounds. Yeah. So,
and again, the creatinine, CK and gastric perf, the numbers were tiny, hey?
Yeah, the GI perfs were just a couple, I think 3, if I remember right. So really low rates. It's in general, this compound looked similar to the other compounds. However, there are some exceptions here. And, the lower rate of zoster was one, and then probably the lower rates of VTE would be the other thing that's notable. But again, all the caveats there about comparing across programs.
Finally, the sperm count issue was one of the things that the FDA wanted more info on. They didn't have the results of the manta ray studies. Comments on this now that has come out and showed the lower sperm rates in the placebo arm compared to the treatment arm?
Yeah, it makes me want to get on treatment, Peter.
Yeah. What about, is it reversible, do you think, or we just don't know if there's any, is it a true issue for this drug or not, do you think?
I don't know that it's a true issue. I mean, from what I've seen from that data, it sounds like it's not an issue. I haven't seen a full accounting of everything yet. I don't know, maybe you have, but yeah, it seems like it's not an issue. And I guess my position was, even if it was an issue early on, before we had more data, this was something that could be dealt with. I mean, obviously you could steer the drug towards people where they don't care about the sperm count. So females would be the obvious choice. And then, maybe some older men don't care about that thing. So,
and we've been using cilazopiram, which does the same forever without it being a major issue. So thank you so much. Last question. Do you think it's a safer JAK? And do you think the selectivity is the reason why?
I don't know, and I don't know, but I think it's worth hypothesizing. It's a good hypothesis, and it deserves further testing. And the data would suggest it's a reasonable hypothesis to test, but I don't know. I mean, I think one of the issues too, and you saw that with oral surveillance, TOFA 10, when you start pushing these doses, everything becomes less selective and they become more pan-JAK like. So at higher doses of all these compounds, they may have some overlap of some of these rare side effects that we're just not seeing at the approved doses or lower doses. So, I don't know. I guess I hold out hope. Maybe this one's safer. Just it's always good to have a safer drug. But I kind of think, again, if you look at the doses across the JAKs of the approved doses, and then you look at, younger, particularly people under 65. I mean, the rates and risks, they're pretty much similar across the board, right? You're not going to get in the same kind of trouble with a younger person as you are with, someone who's got a lot of comorbidities who's older. So I don't know that it was very fair of FDA to label all the JAKs the same way. I probably would not have done that. It wasn't necessarily data based in my mind. I mean,
and all different diseases, like ones with no risk, like AS and PSA.
Yeah, exactly. So that's not how I would have handled that. Nonetheless, they did. It seems to me that with further study, it's something that could be undone and made more specific over time. So hopefully there'll be more studies on these questions, and we'll be able to pick apart the FDA label and make it more appropriate to each drug.
Excellent. So take home message from this study for the practicing clinician.
Yeah, if you're in a place that uses that has access to Filgo, I mean, I think the take home message is you should feel good about using it. Keep the oral surveillance data in mind. I think it suggests there are some potential risks that we didn't necessarily see in this program, but as for now, it looks like it's either similar or safer than some of the other JAK inhibitors, at least with a couple of these specific outcomes.
So thank you again for your time, Kevin. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets are available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or other podcast media. Rate us 5 out of 5 so we can keep this thing going, and let us know what you think. So thank you very much for your time, Kevin. Greatly appreciated.